Obstructive sleep apnea, part 4. So, if you want to get a complete idea about obstructive sleep apnea, please go through part 1, part 2 and part 3 and then watch this part 4. In this part 4, we are mainly going to deal with surgical management of obstructive sleep apnea. Now, when we have decided for surgery, so the first thing is admission. After admission, we are going to take a concern from you. In that concern paper, it will be written your diagnosis, that is obstructive sleep apnea and the grading too. Then it will be written the surgery, what surgery it will be going to be done on you. So most of the patients with suffering from obstructive sleep apnea, they need more than 2 or 3 different surgeries to be done at the same level to make them comfortable. So the different surgeries to be performed also will be written in that, and the complication. The main complication will be bleeding postoperatively and airway obstruction postoperatively. I'll tell you about that. So that will be mentioned. So main 3-4 points I want to tell you in the concern. It will be mentioned that after surgery, you will be kept in intensive care unit ICU for at least 24 to 48 hours for close observation. And sometimes maybe in the ICU, you will be kept intubated. That means the endotracheal tube which they give for anesthesia, that will after the surgery, it will not be taken out. Along with that, you will be connected to a ventilator machine and you will be kept in that state for 24 hours or maybe 48 hours. Why? Because your operation has been done at 2-3 levels and post-operative, there will be swelling in that level. So if you happen to take out the tube, like how we do for a normal case, maybe you will go into airway obstruction and we have to do an emergency alternative for the airway and we make a hole here which is called as tracheostomy. So we will take a concern from you for tracheostomy also. That's what I have mentioned here. So this tracheostomy will be done before the surgery as a planned elective surgery, planned one elective tracheostomy, or maybe it will be done, this tracheostomy may be done after surgery when there is a trial of removing the tube and the anesthetist has failed to remove the tube, then maybe we will do that time. What I do is I decide as per the patient. I judge the patient, the condition, and see whether, suppose I do operation at more than 3-4 levels, especially the base of the tongue and all, I like to do tracheostomy prior to surgery, or otherwise it will be post-operatively if it is in case of failed extubation or removal of the tube. That's what I usually do. So the concern will be for intensive care unit admission post-operatively for 24 to 48 hours. And you will be kept connected to the ventilator and the tube will be kept inside for 24 to 48 hours, and maybe we will perform a tracheostomy for you. And after that, the concern will be a high risk concern. Why? All these patients, obese patients, they have multiple comorbid conditions. They will be diabetic, they will be uncontrolled hypertension, fluctuating blood sugar level, they have cardiac problems. So because of that, we will take a high risk concern from you. And we will do investigation. What all investigation is necessary to take the patient to the operation theatre, we will do all those investigation which comes under pre-anesthesia panel. With all this investigation, we have to meet a physician and for clearance for surgery. And most of them, they ask for a cardiology clearance, and cardiologists will ask for a ECG, a chest X-ray, and they may ask for an echocardiogram also. So once that clearance is over, with all this clearance, we have to meet an anesthetist and he will see whether you are fit for surgery and what are the risks for surgery and what type of anesthesia, and he will explain in detail about it. So once everything has been decided, the next day is the surgery. Prior to surgery, one day night, that day night, from night 12 o'clock onwards, you are not supposed to take anything, drink anything or eat anything from 12 midnight. So next day is surgery, and most of the case, it will be multiple surgeries like how I mentioned. The maximum number of surgery in a single patient, what I have done is 7 different surgeries at the same time for the same one single patient. And that patient happened to be discharged within 6 days. With God's grace, he has gone home fine. Now, the multiple surgeries to be done. So let us see the different type of surgeries to be performed. Now, if you watch the part 1 of obstructive sleep apnea, you will see that the obstruction can be in the nasal cavity, or it can be behind the nose, or it can be at the mouth, or it can be behind the mouth, or it can be lower down. So most of the main cause for the obstructive sleep apnea is behind the nose and behind the oral cavity. That is where you have collapsible structure in their upper airway. So these patients may have nasal problem at the same time. So we have to deal with the nasal problem also. So let me tell you all the different type of surgeries which is done in these type of cases. One, to start with, on examination, if the nasal septum is deviated to one side and blocking the nose completely, we have to make the septum straight, and that surgery is called as septoplasty. 1. 2. Suppose a patient has got polyps inside the nose. The cause can be chronic rhinosinusitis or allergic rhinosinusitis, and that polyp has to be removed completely. That is 2. That we do functional endoscopic sinus surgery. Or if there is a nasal mass behind the nose, like behind the nose means this structure. This is the nasal cavity, and this is a part which is behind the nose. So if you have a mass here, that mass we have to take a biopsy and we have to remove the whole thing. That is third one. Now coming to the main surgery which is done for obstructive sleep apnea. So with this equipment, it has got a small wand. It will be introduced into the soft palate here, and it will reduce the volume of the soft palate by radio frequency technique. That is one technique. So this technique, it can be combined with other techniques in the OT, or this technique alone can be done as an outpatient procedure. This is one technique. The second one is we can implant pillar implants in the soft palate to make it stiff. So this also can be done along with other surgeries in the operation theatre, or just this pillar implant alone can be done as an outpatient procedure also. So you have, in this picture I have shown you 3, one midline, one each on either side. Maximum of 5, total 5 we can implant, depending upon how the patient, what the patient needs, depending upon the response of the patients. So this is one operation where we remove the part of soft palate and the uvula and the tonsil the walls of the tonsils also. It's little aggressive surgery. Actually, we don't do this aggressive surgeries nowadays. So instead of that, what we do is, as shown in the first diagram here, we release the palate on both sides like this wedge, mainly with the cobblator or the radio frequency, or with a scalpel, that is harmonic scalpel. What I do is with cobblator. So we will release like this. At the same time, when the tonsils are hypertrophied, we remove the tonsils also, and we give a lateral release and we switch it off to the side walls. That is one technique. And the other one, at the same time, you can have barbed sutures so that you can dilate the posterior part. That also can be made use of. So if by doing all this, the patient doesn't get much of improvement, then we can go for little more advanced surgeries. So in that, what we do is, this is a mandible, that is a jawbone. So this particular part of the jawbone here, that can be cut open and advanced anterior forwards. Why? Because just behind that, the part of the tongue is attached. So if you do like this, what happens? The tongue is pushed forwards so that you can get enough space behind the tongue. So this is called as genioglottal advancement. Genioglossus is nothing but the name of the muscle which is being advanced. So another one is in those patients where the base of the tongue is obstructing and it is macroglossia. And if you can remember, in the part 3 in the investigation, I have part 2 in examination, I have told you that when you do a nasopharyngeal laryngoscopy, we can see how much of the base of the tongue is obstructing. In that case, what we'll have to do is the posterior part of the tongue, the midline 2 into 5 centimeters approximately, we will remove it with the help of a laser, or maybe it is a corbulator. So that is called as midline glossectomy, posterior glossectomy. So still more advanced, in severe case, what we can do is the mandible, it can be cut on each side, and this part can be advanced. That is, we have a team of doctors, ENT along with maxillofacial surgery. Not only mandible, at the same time we have to advance the maxilla. Maxilla is the upper part of the bone. That also can be advanced. Now, the last one is tracheostomy. Actually, for surgeries for obstructive sleep apnea, the first surgery which was done for obstructive sleep apnea was tracheostomy. Now, this is the rarest of the surgery which is done for sleep apnea, except for a short term before the surgery or after the surgery. This is not for a surgery treatment as such. This is only for the other surgeries to be done smoothly, so that they don't get an airway obstruction. That is about tracheostomy. Now, the postoperative period. If you see the postoperative period, like how I have mentioned, you will be kept in ICU, intensive care unit, for 24 to 48 hours. You will be intubated, the endotracheal tube, the tube for the anesthesia gas to go in properly, that will be kept and connected to the ventilator, and maybe we could have done a tracheostomy for you, and that will be kept, the tracheostomy will be kept only for 2 to 3 days, that's all. If the endotracheal tube is removed, we'll do a tracheostomy and take it off. So this tracheostomy tube will be kept only for 2 to 3 days as per the response of the patient. Then you will get a course of IV antibiotic will be going on. At the same time, we will give steroids also. Steroids has got so many side effects, but since you are in the ICU, all the side effects will be well taken care of. So antibiotics is going on, painkillers are on, and after when you recover and everything is fine, you're extubated, everything is okay, we'll start with the nasal wash also, if we have done a nasal surgery at the same time. And throat gargle when you're comfortable, and we'll advise you to drink plenty of water. Now, the discharge time, the take home message. So when you are discharged, most of the time, even the severest of the patient, that is what I have mentioned before, that I have done about 6 or 7 surgeries in a single patient, even that patient goes home by 6 days. In fact, he goes home driving of his own. So the take home message will be, you have to don't depend on surgery completely, you have to lose your weight. So your diet should be well under control, and during discharge for next at least for 10 days, your diet is going to be cold and balanced diet. Nothing warm, nothing hot, nothing spicy. Why? We have done so many surgeries in the oropharynx and oral cavity. Anything hot and spicy, it can induce bleed. So if suppose you have bleeding, there is no other option other than to take you again to operation theatre and see the bleeding and get it controlled. So please avoid any sort of complication. To do this, we have to be in cold diet. That is one. Avoid warm, hot and spicy food. That is 2. And at home, try to avoid a hot shower. Do not lift heavy weights. Do not strain. That is 2. Regular exercises, that's a must. Regular tongue exercises, which I have already mentioned before. Regular body exercises, that's in the morning and night. That will be, don't overstrain yourself for the initial 10 days. After about 2 weeks or 3 weeks, you can go in for regular exercises. Then, normal yoga breathing exercises is very good. It's good for the nasal cavity, the upper airway completely, inclusive of the lungs too. So that is, please do that. Now, to know the report, to know the result of the operation, what we can do is, we can repeat the polysomnography or sleep study, which we have performed pre-operatively. So this sleep study can be repeated after 3 months or 4 months after surgery. And sometimes we may need to use the CPAP after surgery if the patient is not that comfortable, the oxygen saturation is not going up above 92, 93. So that too, this PAP machine also, we are not going to keep it off for long. We are going to keep only for maybe 3 for 4 days, and it will be taken off. So after that, you have to follow all this advice and weight reduction and come back to normal at the earliest. And the success rate of all the surgery is going to be 50 to 60% only. The rest is in your hands. You have to reduce your weight and take care of your diet and take care of your body well, so that the success rate increases from what I have said. So it can be increased much more than that. So that is about obstructive sleep apnea, which I have discussed in as 4 different parts. Part 1, which is an introduction, and what is sleep, what are the stages of sleep, and how do you classify sleep apnea, what are the stages of sleep apnea, and what are the causes of it. In the second one, the patient complaints, part 2, I have dealt with patient complaints, examination, what all we will examine on you, and what are the procedures we need to do, what are the investigations, and mainly the polysomnography sleep study in brief. The part 3, I have dealt with non-surgical management of obstructive sleep apnea, and this part is mainly about surgical management. Thank you so much.